whakarongo rā. Whakarongo ake au I te tangi a te manu e re re ronga rawa e. Tui, 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 tui a, tui a I ronga, tui a I raro, tui a I roto, tui a I waho, tui, tui, tui a. O tēnā rā koutou. I te tuatahi, kei te mihi ahau ki te tangata whenua, kua whakatau mai I a mātou I tēnei rā, tēnei te mihi ki a koutou. He rohi ātāhua tēnei, and he honeri ki te noho ki tō koutou taha. I taku mihi tuarua, aha kōkare anō kua taimai, he mihi anō hau ki te minita hauora, ko Mr Coleman, tēnei te mihi ki a ia. He mihi tuatoru ki te rōpū whakahaere o tēnei hui, ko te Rural GP Network, tēnei te mihi ki a koutou ki a whae he wāhi, ki a kōrero mā tātou mai I te hauora pēnei. Ki a koutou katoa, raurangatira mā, ngā tākuta hauora o te ao nei, tēnei te mihi ki a koutou, nā tō koutou mahi, ka whai oranga te whānau, tēnei te mihi ki a koutou. Ko wai tēnei e tuaki mua koutou, ko Michelle Mako, I puta atua hau ki te rohi o hora whenua, no ko nei hoki a hau. Tēnei te mihi ki a koutou. Thank you. It's a real pleasure to be here today. As my introduction says, I work for the Health Promotion Agency, and it's a great privilege for us to be partnered with the Rural GP Network. It's a second year that we've been partnered with this group. We think there's a great lot of heart and spirit and a huge opportunity to promote wellbeing for our whānau, for our communities, and so we really are very blessed to be part of this conference. So who is the Health Promotion Agency? We're an organisation that has a mandate to inspire New Zealanders to live healthier lives, and we do that through our work and working and supporting you and the work that you do. So we're really, again, very grateful to be part of this conference and to be part of your network. I have been given the great pleasure to introduce Lance today. You've got his bio in the book, so I'll not spend a lot of time going through that. But some key notes we should acknowledge. Lance has been nominated as the Kiwi Bank New Zealander of the Year for 2014. He was he won the Peter Blake Leadership Award. He was the Public Health Association Champion for 2013 and the TVNZ Māori of the Year 2012. It's quite a lineup. I suspect through the little bit I know about Lance, that actually probably his greatest accolades come from his communities, the people he serves, and I'm sure those are the accolades that he carries closest to his heart, so I'd like to acknowledge that. Lance has been an inspiring leader, so I talked about this mandate for inspiring New Zealanders, and I'm pretty well aware that you can't do that through advertisements, TV, commercials, posters and pamphlets. What you need is to move from providing information to creating opportunities for transformation. And I think we have in our midst, both with Lance and with all of you, real opportunities to create that transformative approach in communities, not just about telling people how to live their lives, but actually creating opportunities and environments in which that can occur. So it is a great honour to be here. And a great honour also to be with Lance. So, this is a man who gives much to his community, and so we acknowledge him for that. I'd also like to acknowledge him as a role model, someone who doesn't just talk the good talk, he's out there and he's showing what that looks like. And last weekend, Lance and I were very privileged to be sponsored by Ngāti Tūwhare Toa to complete the Kellogg's Ironman. So we crossed the finish line pretty close to each other last weekend, and I would also like to acknowledge Lance for his efforts. And my husband was on the course, took this photo of Lance doing the business, supporting the Iron Māori Tour cause as well, which is very much, again, a community-led transformation about Māori living healthier lives. So that's enough from me. Tēnei te mihi ki a koe, e rangatira, he pai hoki ki te noho ki tō taha. Kia ora.
Kia ora no tātou e te whānau e tau anō ngā mihi ki te hau kāinga, ki te whenua hoki, nō reira tēnā koutou katoa. Thanks, Michelle. Michelle, thanks for the introduction, and you have a beautiful voice, and you also are a really great athlete, because she actually came ahead of me in the Ironman by 35 minutes, so mai te paki tātou wā. And it was great to have such a turnout down there from the community that the communities that we're working in. So, yeah. So kia ora everyone, and thanks for the organisers for the opportunity to come along here today. I'm excited for a number of reasons. The theme of the conference is, well, the title of the conference is Close to Home. So it is really special for Tracy and I to come here because it was home for us for 5 years. Tracy, my wife's whānau, from here. Our children's pito, or whenua, is buried on Makoia Island, so the whenua is the placenta. So after the birth of our children, just over on Makoia Island is our children's whenua. So we have a really strong connection to Rotorua in terms of a family sense. It's really a privilege to be here too in terms of this conference as a rural health practitioner, because this is where I cut my teeth, so to speak, as a GP, firstly, and then as a person who wanted to develop a strong interest in rural health medicine. And it was here that there was, leaders and people that inspired me to say, GP is a wonderful career. And there were people like John Armstrong, Neil Poskett, Clem Lalive, Bernard Conlon from Murupara, and I don't know if Bernard's here, but people that planted the seed of passion and desire to provide a quality and skilled and passionate service in the area of rural health. And then there was also real strong cultural mentors too, like Mita Mohi, who's one of my mentors when I was down here. So this is close to home for a couple of reasons, family reasons, and I guess a beginning of a career. So just to acknowledge all the delegates that are here today, doctors, nurses, health professionals, aligned health professionals. It's in old faces and new, so meaning people I know, people I don't. So it's really, really good to be here. Also, and acknowledge our family that are still here, our whānau that still live here. So, I actually made a mention. It's a shame our Te Arawa whānau have gone. Actually, the kaumātua on the front bench here look the same as I did when I left here almost 9-10 years ago. So they're in good hands. And I guess that's a little bit about where my journey started, because 5 years here, cutting my teeth in Rotorua, we had this opportunity to go to a place right up to the top of the country called Kaitaia, and we sort of saw there was a need there for, in terms of doctors' numbers and the health outcomes that were sort of happening up there. And so we took our whānau, we took our set of skills to the far north. And just to acknowledge the table from the far north here. So, So look, I guess this is a photo here of myself and our son, and he's our 7th young child, and his name's Lance. So when you have 7 children, you run out of unique names. And so his name's Lance, and so this is a photo I use, and you've heard this story before, Leanne, forgive me. This is a story, this is a father and a son who are embracing, and the father's looking at his son thinking he's just full of potential, full of positivity. The son looks at his father and knows that he has support, guidance that will send him through his life. It's a New Zealand's father, a New Zealand son, a parent and child photo, a Kodak moment that I think every parent should have in New Zealand. And we just, we're here to also talk about equitable access, which is one of the themes of the conference, knowing that that's not the case for every parent and every child in New Zealand. That's something that is particularly important for me. And I guess I hope from the end of the presentation you'll get a sense of how I think I'm trying to display leadership and in the area of trying to ensure that, at least in the community that we serve, that there's a chance for this Kodak moment to happen for every parent, every child. So that's the background to that. Okay, so the themes of the conference, kia ora Minister, is equitable access, affordable, quality primary healthcare. I've thrown in a couple of other ideas or subject headings that I think could also be applicable to a conference like this, which is unique to rural communities, healthcare to rural communities, and that is leadership and innovation, innovative models of care, because there's a lot of factors, and I don't need to convince you all here who are experts in providing care to rural communities, that we have to have innovative ways of delivering healthcare because of geographic isolation, social isolation, cultural differences, and workforce challenges and issues. So in the issue of leadership, I guess I seek to display that and demonstrate that is that we have an important role to be leaders in our communities, and I think we can, not shy away from that. And whilst there's a burden there, there's also an incredible privilege in that responsibility. So I've sort of looked at a few areas in those titles that I wanted to talk about today. I think it's important to give a little background as to who I am, because whilst there's some titles there, which I'm really, really privileged to have received, some awards, etc., there's a little bit of a story that makes this a little bit richer, I believe, in terms of, I guess, and it'll give you an idea as to why I seek to the roles that I currently am performing, and I guess the passion that drives what I do, and the what I do and the why I do it. And I sort of refer to this why a bit because I believe this talk should leave you with a few whys, both why there's some answers perhaps to why we're doing what we're doing, but perhaps a few more questions around the why. So essentially, this is my background. Is I was born to a Pākehā mother and a Māori father in, I guess it was National Women's Auckland, in a context of some of those social dysfunctional sort of factors that go on in families that we deal with every day, which is, I guess, alcoholism, violence on occasion, and cultural disconnect. And I think and believe that a lot of the challenges that we have, that we face, certainly I do, in a health setting, is underlined by these sort of factors. Okay, so here I was, born with my mother, and that's us up on going for a ride, with a brother and sister. So being raised by a Pākehā mother in the eastern suburbs of Auckland, quite quickly a solo parent family who was a welfare family, so we benefited from the compassion and generosity of a society that says we will help those in need at a time when they're in need, because if we don't, they will end up statistics, or we deprive them of the opportunity to be greater than they could have been. So here we were, so my mother did her best to raise children in a context of a whole lot of ism, classism, because we're welfare people, and that was really apparent. Sexism, because she was a solo mother, and we would have men turn up on my mum's door sort of demanding that her kids get a kick up the backside because of what we'd done, and that wouldn't have happened if we'd had a father who would meet that man at the door. And racism. And that was a real challenge, because all my Māori cousins called me a honky, and all my Pākehā neighbours called me a nigger. I really didn't know what I was. And I say that lightly, but those sort of isms have the potential to impact hugely on a person's formative years. And I want to use this analogy and keep it in your mind around how would that affect the health outcomes? How would that affect the people that we might be seeing tomorrow or on Monday? So quite quickly, this young, half-caste Māori kid, as I was referred to, from a solo parent family who was on a benefit in the eastern suburbs of Auckland, got quickly labelled as a slow learner, as a troublemaker. It ended up in the principal's office, and some would say that hasn't changed a lot, but with a dunce's hat sitting in the corner, and literally my mother being told, getting back to my mother, your son's a slow learner. So quite quickly, that would leave this young man sitting at the back of a class pretty disinterested in education. Now that's a trajectory that's pretty scary, and it's probably going to result in a whole lot of problems socially, justice-wise, health certainly, and as a citizen in New Zealand. So I'm telling this story because I think there's analogies to the people we're seeing every day, and there's analogies to how we, as workers in a health system, can respond to those presentations like this. Because what happened shortly after this sort of period of being disinterested kid at the back of the class, was I got expelled from my first college. Okay? So I was failing in the education system. Well, the flip side to that was the education system failing me. So was I a slow learner, a troublemaker, who just wasn't going to succeed anyway, or was I a child in an education system that didn't have the right tools in their toolbox to educate me and inspire me? And if you think about our health system, how many of our patients is the health system failing versus are they failing in our health system? So yeah, that's me. So you probably picked up that I got expelled from my first school, right? College. So the natural conclusion is, I got expelled for a second college. Okay, so I was bundled up by my mother at age 14 and sent to a place in the South Island called Timaru. Went to Timaru Boys High. My Catholic grandmother got dressed in her Sunday best and took me along to a Presbyterian school. And do you know how hard that is for a Catholic? With her Sunday best, gloves, hat and all. So she took me along there and she said to the rector of the day, look, could you take my grandson, because if he does well in the next 3 months here in Timaru, because I was staying with my auntie and uncle. My uncle was married to my mum's sister, was a Māori man from the East Coast. She believed that what an important thing that was missing in my life was my culture. And so this rector said, yeah, we'll give him a chance. So it was about 6 weeks after I started there that I got expelled from Timaru Boys High. So, and a funny thing happened recently, about a year or two ago. There was an article about what we're doing up in Kaitaia by Guy and Espinard in the Listener. And the chairman of the Old Boys Association of Timaru Boys High said, we have no recollection of Lance O'Sullivan ever coming here. And it's funny because there's an assembly about 300 strong boys like this that I got, marched up, called up in the middle of the assembly, marched to the rector's office and said, get lost. So I remember that. There's just some record keeping, I guess, but I also think that perhaps the old boys, the Timaru boys community didn't want to be known for expelling the future New Zealand of the year. So. But look, things had happened to that point that had meant that my trajectory for success or otherwise was being predetermined, not because of my skills or my inherent abilities, but the context that we were raised in, and also the response of the environment to who we were and what we were at that time. So I think it's really important to talk a little bit about me, because I don't think I think the awards that I've had are really humbling and a privilege and an honour. But I guess that story is really important because that's what drives my desire for leadership, my passion for what I do, what we do, and my sense that we have to really rethink always. Is it us failing? Is it our students failing in our education system, or is it us as teachers or part of the cogs in the machinery of education system, or indeed health, that are failing the people who are using our service? So, yeah. So you're probably wondering, there's a big gap between sort of getting expelled from 2 colleges and ending up, standing here, doing Ironman, talking to this illustrious group. And I guess what the difference is I was inspired. I was inspired to believe that I was capable of doing something. And so I went to a college called Untitled Chapter, which up until that time, I didn't have a sense of self-belief, who I was. This is the importance of cultural identity, self-belief. So I went along to the school, kid with a chip on his shoulder, head down, and graduated at the end of my 7th form year, believing I could conquer the world. What was the difference? Well, it was the idea that I actually knew who I was, and I was proud of who I was. Proud of who I was, not as an individual standing in front of you, but as a descendant of my tupuna, a person who had a mission, who wanted to create a movement or be a part of a movement around a particular passion that developed over my time at Untitled and probably was developing when I was a younger boy. So I witnessed too. I witnessed leadership. I witnessed inspirational people, both in front of me, my readings, my exposure to, this concept of proud Māori. So, and there's some of them there. Sir Toby Curtis is a local inspirational leader who's in the education field. And actually there's the 2 Māori doctors there, Sir Maui Pomare and Te Rangi Hiroa. Okay. Doing the wrong one, that's why. I was probably red dotting you in the face, sorry Michelle. Looking back, because again, reflecting on the themes of the conference, equitable access, affordable primary health care, leadership, innovative models of care. So as you probably guessed, I graduated with a desire to contribute to New Zealand society by ways of, a particular focus for me at this time in my life, which was started in Rotorua, ended up in Kaitaia, a focus on particularly around Māori health and inequitable health outcomes, providing leadership. So what are the things that keep me going? Well, things like the fact that the history of our country is that, from whatever number you pick in terms of pre-colonisation Māori numbers in New Zealand, it was higher than 42,000 at the turn of the century. But so what happened was we had a physician who at some stage in his career said that it's the duty of the European race to smooth down the pillow of a dying race. And that was about 1850, he made that comment. And by 1896, he's almost accurate with regards to the near extinction of the indigenous race in New Zealand. So that was war, famine, child death, maternal death, etc., etc. So, but importantly, Māori people didn't die off, and today 643,000, or at least census 2013, shows that quite a resilient race actually. Morehu means survivor. So quite a resilient race. And that's despite all of those diseases and famine and other insults. However, as you all know, there's still work to be done. So the resilient race has survived. but there's still significant inequity in terms of Māori, non-Māori health outcomes in Aotearoa. Now, third world disease, rheumatic fever, obviously, high profile condition. A lot of input today at the moment around that, but think of bronchiectasis, think of other inequitable diseases, tuberculosis, et cetera, and then chronic, NCD diseases, heart disease, diabetes, cancers, et cetera. So there is a concern because there's this gap of health outcomes that is unacceptably high, and I certainly am on board with the movement of trying to reduce those, as many other people in this room are. Now, I just want to talk to you a little bit about just a snapshot, and this is something I talk about with people because I think it's something you can take home to your practices on Monday. That if you look at the census data from 2013, 48% of children in Northland between the ages of 0 and 4 are Māori. And that's compared to a national average, which is half that. Now, the only concern there is that only 12% of Māori over the ages, people over the age of 65 in Northland, which is where I reside, are Māori. So, there's a massive drop between those that are born in Northland as Māori and who actually reach older age. Anything under the age of 65 in terms of death is considered premature and a waste, a loss to a cultural loss, a societal loss. And so what happens to result in 1 in 2 children under the age of 4 being Māori, from them being 1 in 8 in terms of over the age of 65 over lifespan. So, and actually if you're Māori living in New Zealand, the best place to be is Northland, because over the age of 65 they have the highest number of Māori. That is the region with the highest number of Māori over the age of 65. So it's not like they're moving to other regions and we're just losing them to immigration, or they're moving to Australia and even coming back. That's a possible thing. But it's premature disease. It's infectious disease at a young age. It's injury. It's accidents. It's chronic disease. It's suicide. It's all of these things that we work really hard on a day-to-day basis. But the important thing for me is, 3 out of 4 Māori children under the age of 4 that come and see us in our clinic in the north will die prematurely. And so the question we could have is, is how can we address that? 3 out of 4. So we see 4 Māori children under the age of 4, 3 of them will be denied an opportunity to grow old in our country. How can we change that? That's quite an important thing to take home. Okay, so my job. So I'm really love the job that I do as a rural general practitioner in the far north. So it's pretty much, that's me riding home on the Awanui Strait and the Waipap Strait on a starlit night after working in the hospital. Paperwork, results, inbox, all that, referrals. And so I've got a farmer's bag that's got this massive crayfish. There's a little lamb there that's sort of greeting me, but there's also a dog there. So we have a very harmonious family life. And it's rural health, rural general practice is rewarding. So the consultation room. So it's obviously the typical consultation room, but it's also the pack and save supermarket. It's the swimming pool. It's the times where you go, "Oh, Tracy, can you go into the shop because I'm going to get hit by the 5 people that just walked in front of us." And so a story is, this is Pack and Save Kaitaia, and so I was there doing the shopping, and someone came up to me, one of the patients, and said, "Oh, Doc, I've got a problem with my dick." "Oh, okay. I've got a lump." "Oh, okay, you got a lump." So I'm here with, the Weet-Bix. And I said to him, "Okay, look, tell me about it. Symptoms, discharge. How long's it been there? Family history? Any other complications? Weight loss and all this sort of bizarre things. And 2 things happened. I referred him to the urologist, and I didn't go down the cereal aisle for about another 12 months. But all you guys will know about this, being rural practitioners. It's the richness and also the burden of being a rural practitioner. In this case here, I was at the swimming pool, and someone had a cardiac arrest there. Long and the short of it is, I was about to fly out to Iron Māori on a plane, and someone come running past, quick, call an ambulance, there's someone who's had a heart attack. And sure enough, this person had a heart attack, and there was a coronary care nurse, Lorraine Parker, and another senior lifeguard, and we did CPR on this patient, shocked them and gave them adrenaline and everything for about, seemed like hours, as you know. And then he came back about a few weeks later, gave us some snapper, He'd been down for about 20 minutes, so that's real cool. But, that's the richness of rural and the burden of rural practice. So just a little bit about us. So Tracy and I, we started a company. We wanted to do something different because we didn't want to. We got a bit tired of working in a box with a set of rules that we didn't think fitted our passion, our desire, our sense of wanting to change things. And so we created this company, and we have a general practice. We have quite a few staff now. We've played around with a bit of research. We're certainly not experienced or, hardcore researchers, but we've got some exciting things that we're doing, and we're really keen on looking at innovative models of care. So that's some of the staff we have outside the Kaitaia Hospital. There's some medical students there too. So equitable access, one of the themes of the conference, really important. And so we started off this idea of a walk-in clinic, because we know my history in terms of general practice was the community I wanted to serve, the population of people I wanted to serve, they didn't get along to booked appointments. They didn't have the time on that particular day to make it. They didn't have a phone to ring in for an appointment. They didn't have, someone to look after their kids. They had all these social stresses going on. The times that suit us don't suit our patients. So we went through this idea of a walk-in clinic. It's not novel, it's not new, and many of you probably do it, but we're the only one who does it in Kaitaia. And it's really works well. We survey our patients with a survey monkey in the waiting room. They said, yeah, that works well. We like this. We can get care on days that we need. We think that ensures better than equitable access for the patients that we serve, which are very high needs. 95% of our patients are high needs. It makes for a bit of a busy day, because you're a doctor, you walk in the morning, you don't know whether you're going to see 5 or 35 patients in the morning. So it's busy, and it doesn't always suit us, but we've got to rejig our patient flow. And so we use a lot of healthcare assistants, nurse practitioners, and registered nurses to run our walk-in clinic, and it works really well. And it's a little bit concerning, because this Westminster style of general practice that we believe fits every community and we should apply to everyone, doesn't work for, which is the 15-minute appointments in the morning, in the afternoon. You ring, you make an appointment, and it doesn't work for everyone. And concerningly, I hear that, in Kaitaia, they're thinking that one of the proposals for after-hours care is actually that people would ring our health line and they'd get a booked appointment for after-hours clinic. And, that after-hours clinic might go for an hour and a half or whatever in the evening. But I have grave concerns that the reasons for why we changed to a walk-in clinic type model, which was people don't have credit on their phone, they don't have access to a car at the time that you give them an appointment, they don't have babysitters, etc. I think that will be replicated in this suggestion, which is only a suggestion, to actually have booked appointments for after-hours care in Kaitaia, which concerns me, because we shouldn't be replicating our mistakes, I believe, which is having a health-centred or health system-centred approach to how our patients access care. We should be going back to patients and asking them, how will it work with you, given the resources we can provide. So also we have this Moko Health Service, which is really exciting in Kaitaia. We have we have staff going into 14 schools around Kaitaia, seeing 2,000 children for a range of problems, NITs, skin infections, sore throats. And, as any of the parents in Kaitaia would attest to, if you ask any of the families in Kaitaia, this is a really well-known service. the families, the parents know about the moko team, the children know about the moko team. It's incredibly successful, and it's about trying to shift perhaps the delivery of care from what is traditionally, maybe, this is how we've always done it, but it's not necessarily how we always have to do it. And affordable. Interestingly, when we opened up our practice 2 years ago, 2 other practices in town dropped their fees instantly. That was not a philosophical change. It was commercial pressure. And that was really interesting, because what is affordable in terms of delivering healthcare? How unaffordable are we making healthcare? Okay, so I know I've got to keep going, so I'm going to have to rock on through. The moko program we run, it has over 90% consent rate, so people, they like it. We have lots of things going on that's more than just service delivery, like intervention with antibiotics. We talk about health promotion stuff, injury prevention, keeping kids' nails cut short, and how to washing your hands and all sorts of things. But also if you go into any school in Kaitaia and ask children at any age what the mōkapa team do, they'll tell you one of 3 things: skins, throats, kutus. If you ask them what would they do if they had a sore throat, any child, I can bet on this, will say, you get a throat swab with the mōkapa team. What's it looking for? They'll tell you it's group A strep. What are you trying to prevent? They'll tell you it's rheumatic heart disease. What do you need if you have group A strep? You need antibiotics. And in some cases, you ask them what antibiotic, they'll tell you amoxicillin. And if you ask them for how long, 50% of them will get it right. They'll say 10 days. And then you can do the same thing about sores. Okay, so probably a really important outcome is not just how many scripts you write, but how much increase in health literacy we're creating in children. These are 5-year-old children that I'm talking about that can tell you that. So those are children engaged in healthcare now that in 10 or 15, 20 years' time are going to be more health literate, and therefore they're going to have better health outcomes. So that's really exciting. We had a moko games. So Top Town, rural people know about Top Town and stuff. We used to have this all the time. So we created this moko games, which is equivalent to Top Town. We had games where they had the haki crawl, I believe, the kutu something, the strep striker, and there's a strep striker there. They had a little pole with like a big throat swab, basically. They had to throw it into the tonsillopharyngeal recess. And lots of fun things. So we just had a fun day. All the kids come along. They did this wicked haka at the end, a haka off, and they all went away with this little trophy. We didn't have to do it. It was just, we wanted, it was so awesome. These kids had such a great day, but we were putting out there, we were promoting health messages to these kids. Okay, so the why. I talked about, we probably need to always think about the why. And so why do we have an important focus on equitable access? It's to prevent, if you've got early intervention, you've got equitable access to healthcare, you're going to have early intervention to prevent later complications. If you can prevent hospitalisations, you will prevent cost to the family, cost burden to the health system, health disparities, obviously, and a fairer society which is more equitable is a better society for us all. We know that. There's that fluid level, I think. There's a book there. Have a look at. So going on to quality primary care. I'm preaching to the converted over primary care because you are all primary care practitioners, but a particular focus I wanted to mention was MRSA, so how we're trying to maybe even create a best practice guideline or a best practice approach on MRSA management in high needs communities, coming out a little old Kaitaia. So there's this important issue of MRSA, the superbug, which afflicts a whole heap of our people, and we did some research with a medical student with the Health Research Council funding, which showed that actually 68% of the children that have MRSA in our practice, which was our general practice and also our moko database, which is a combined total of about 5,000 people, 68% of them were under the age of 14, 33% were under the age of 4. So it's a significant burden for vulnerable people. 95% of them were DEP 4 and 5, 95% were Māori. So MRSA, presenting as what we see every day in our practice, which is skin infections, but it also is eye infections, urine infections, pneumonia, and intrathoracic infections that I'll talk about soon. But the important thing is this is a young baby who came in with a mother who was about 8 months of age, who had had this infection for about 5 months. Walking down the street, this mother would probably be looked at and judged and say, gosh, don't you look after your baby? That could be a real burden for someone who's a solo mum on a benefit who actually is trying her best. But actually, when you reflect on this child had been to another practice in the country, because they moved to Kaitaia 3 or 4 times over 3 or 4 months, and been given, I can tell you what it is, you can tell me, it was that foul-tasting medication you have to take 4 times a day, or it was the white one you take 3 times a day with food. None of them had worked. And so, if you put a lens on in terms of health inequities and health disparities, you'd say, is MRSA a possible cause here? And so sure enough, you do a swab, you treat it with Deprim, and that after 4 months, that treatment after 5 days is complete clearance. And so it's about, the quality of the care we're providing that's a challenge. And then the burden on that mother would have been significant, I'd imagine. Actually, she was crying when the child was better. So we did this research. It was really cool. We created a resource from it, which was the MRSA booklet created for our community by the student, and it tells them about MRSA, because if you've looked for any information on MRSA, it's American, it's hospital-based. So we created our own local resource for MRSA, telling about the importance of trying to eradicate it from your family, your whānau. And the burden and difficulty that we scored from the survey was significant financial burden, time off work, and difficulty, stress on already stressed people. These are vulnerable people already that are getting this problem. And so we have this process. We classify it on MedTech, MRSA positive. We send them information. So if we classify it, if you're another doctor in our practice and the first thing you see when you see a skin infection, the first thing you do after a swab is looking at previous classifications to ensure that they don't have MRSA previously. Because if the only time to see you is today, and you give them an antibiotic that's the wrong one, and they can't get back to see you for 2 or 3 weeks, we've perpetuated an inequitable outcome. So the why, okay, well this is from primary health care quality point of view. It's important because complications of MRSA are anything from, like I tell the students, nothing to death. And in our community, we've had MRSA death from pneumonias of children that are vulnerable. And, and recently had a patient who, instead of spending 7 days in a cardiothoracic ward in Auckland for his massive bullous surgery he spent 17 days, 21 days. So the extra 11 days in a cardiothoracic ward in Auckland because he got an MRSA infection in his chest drain. Minister, that's a lot of money. That's at least $20,000, of unnecessary spend, and importantly, a risk that he could have got seriously unwell with it. So it's not a benign condition, this idea of MRSA, and that's why we're treating it seriously. And we'd love to be able to sort of create some stuff out of this that we could go around to our practices in Kaitaia and to our practitioners and say, hey, look, have a process which includes classifying it, having a process for treating it appropriately, and how to eradicate it from the family. So we use intranasal Bactroban. Right. Okay, I've got to rush. I've got 1 minute. So very quickly, the innovative models of care that we're talking about is we live in communities that are rural, isolated, they have social and cultural and other barriers. So we've started down this pathway. We've been going for about 18 months where we use technology to reach people that can't be reached. And so we have this program called V-Moko, so the Moko program we have in Kaitaia serving 2,000 kids. People in other communities are saying, how can you help us? Well, we virtualised it using technology, and we moved it out into these communities in the far north. So we're looking at things like this, with skin infections, which can cause problems like this, which is osteomyelitis of his fibula, requiring 2 admissions and surgery. We're trying to prevent that. That's the why. And we train up local people who are volunteers from our communities We give them some technology, which is iPads and digital equipment with apps, and we get them to, this is the development of the app, and we get them to send us the information on this child's particular health problem, and it's limited to skin problems at the moment, and we give them treatment which goes on a rural delivery. And we're also partnering with someone who's looking at the housing, so the people on this program, their children get access to housing and a housing initiative that will help address those primordial issues that are driving infectious disease and other inequitable disease. So we get things like this that come to us that have been there for a month or 6 weeks, and we can treat it without seeing the child, and they get better. So that could only be good if this child is not getting the care in the first place. The why is, I was at a community in the Whatuwhiwhi the other day, and these kids come up to us and said, hey, you're from the V Moko team, aren't you? Because it was written on the car. And I said, yeah, how do you know that? And he said, well, saw your sign and you guys got me better. I said, what did you mean? They said, we had some sores on my legs and do you want to have a look at them? And they got, I didn't put them on, but they had sores all over their legs that were healing because they had gone through the V Moko. So these are people in the community managing their own community's health. So we're not going in there delivering a service and an expertise and leaving. We're actually going in there, supporting them with technology and advice, and then leaving the people to manage their own care, which is empowering, okay? Care that's closer to home, because these children are 50 k's out of town, and their care can be more readily accessible than coming into the doctors. I actually have to wrap up, so I'm going to just go through quickly, but this is my last slide, Joe, but special mention to, we're rural practitioners. Lance Weller's here somewhere, Lance? Yeah, kia ora, Lance. And so, we are living in rural communities and we are isolated geographically, and I just want to acknowledge that Angel Flight, who we've worked with closely over a number of years now and have helped our vulnerable and high needs and low means families get to places like Auckland Starship Chemotherapy, and just a fantastic resource as a rural practitioner. And I'd just like to, there's some information there, but they're here at the conference, and Lance is amazing. I rang him up one day at about 2 o'clock on a Saturday afternoon, say, can you organise a plane for 5 o'clock on Sunday and to go to Auckland? And he did it for a young girl who's got liver cancer and couldn't tolerate the trip from Kaitaia to Auckland without getting significantly nauseous, which is not a good setup for her chemotherapy. So anyway, that was my final point, as a bit of a plug for Angel Flight. As rural practitioners, please give some thought to utilising this really important service. So that's my kōrero. Once again, really awesome to be here. Nō reira, tēnā koutou, kia ora mai tātou katoa.